Hello and welcome to this Wound Care Today Facebook Live seminar. My name is Trudy Young and I'm the Director of Education and Training at the Welsh Wound Innovation Centre, and I'm the Honorary Tissue Viability Nurse for the Vlinda NHS Trust. Today we're focusing on the diagnosis and management of skin tears. This seminar is kindly supported by Mernlicher. At any time during the seminar you can submit a question by commenting on the video, and I will do my best to answer as many of your questions as possible at the end of the presentation. After the event, you can access your certificate of attendance, which will contribute towards your revalidation and CPD hours. We'll now move on to the presentation entitled "It's Not Just a Skin Tear, the Importance of Correct Diagnosis and Management." So why am I talking to you about skin tears this evening? Well, to me they're a really important issue. I've nursed many patients with skin tears over my career, and what has always struck me is how painful they are for the patient and the fact that it's a preventable problem. So let's look at it in more detail. The learning objectives for this evening are to define a skin tear, to introduce you to the ISTAP classification system, to look into the prevalence and incidence of skin tears, to demonstrate how to treat a skin tear correctly, and the importance of appropriate dressing removal. So I mentioned the ISTAP classification system. So what is ISTAP? Well, ISTAP is the International Skin Tear Advisory Panel. It's a multinational group of healthcare professionals who focus purely on skin tears. And they have produced for us a best practice statement in 2018 on how to prevent and manage skin tears. And the rest of this presentation is going to be focusing on that best practice statement, so I can share the contents with you and hopefully improve your practice. So I would ask you, how would you define a skin tear? I find it sometimes quite difficult because in clinical practice people use lots of different terms to describe a skin tear. The terms I've heard over the years include tears, lacerations, abrasions, erosions. Sometimes they've even been confused with class 2 pressure ulcers. And sometimes they're just described as a skin tear, as though it's not an important issue, which for patients and healthcare professionals is wrong. It's a very important issue. But for us as healthcare professionals, to successfully treat a skin tear, we've got to be able to define it. So, let's have a look at what skin tears look like. The cases you can see on the screen clearly illustrate that skin tears are not just minor injuries. They can be extremely significant and very complex injuries with the potential to develop into serious chronic wounds. Those pictures, I think, are quite harrowing. So what is a skin tear? How can we define this? The International Skin Advisory Panel define a skin tear as a traumatic wound caused by mechanical forces, which include the removal of adhesives. The severity may vary by depth, but doesn't extend through the subcutaneous layer, the fat layer. The mechanical forces can include shearing, friction, and blunt trauma. So a skin tear can be classified as either partial thickness or full thickness. So a partial thickness skin tear means that separation of the epidermis has occurred and it's no longer attached to the dermis. Whereas a full thickness skin tear means that both the epidermis and the dermis have separated from the underlying structures. ISTAP very kindly produced a classification system for us for skin tears, very similar to the way that we classify pressure ulcers. It helps us to standardise terms, and when we're identifying skin tears and then documenting them, the use of the classification system means we're all talking from the same hymn sheet. It's really very helpful. But what's more helpful is the simplicity of the classification system that ISTAP has developed. So let's have a look at this classification system. You've only got 3 types, so that to me is a bonus. And type 1 is where there's been no tissue loss at all. There's a linear wound or a flap tear, which can be repositioned to cover the wound bed. In a type 2, this isn't possible because you've partially lost part of the flap. So therefore that can be put back over the wound bed, but it won't totally cover it. A type 3 is a more severe type, and here we've got total tissue loss. So the total flap loss, it's gone, it's not there at all, so the entire wound bed is exposed with nothing to cover it. So where do we find skin tears? The study suggests that the average distribution of skin tears is 80% occur on the upper extremities of the body, so the arms and the forearms. We do find 15% on the lower extremities, such as the shin or the top of the foot, and then the other 5% occur elsewhere on the body. And this reflects what I see in clinical practice, with lots and lots of skin tears on the forearms of elderly patients, although I do see them again on the lower leg. So how many have we got? Well, when we look at risk of developing skin tears, a study from the US says that more than 1.5 million people, institutionalised adults, are at risk of developing skin tears. So a high amount. But what about the incidence? In patients over 65 years, the incident rate may be as high as 15%. It's quite difficult sometimes to actually get the figures. Because of the confusion in terminology, it's not easy to find it in the records because there's differences in what they're called. Also, we're very good at reporting pressure damage and pressure ulceration, but we're not as good at reporting the presence and incidence of skin tears, so that doesn't help with the data collection. In addition, the World Health Organization have an internal classification of diseases system where they name the different wound types. But unfortunately, skin tears doesn't feature in this, so that's another reason we don't have the data or collect the data at the moment. The prevalence of skin tears varies across different care settings. In long-term care, it can be as high as 92%, which is absolutely phenomenal. In the community, it's a lot lower, reported to be around 19 to 20%, but that's across all ages of people with skin tears. But what worries me is we don't pay enough attention to skin tears, even though they can be more common than pressure ulcers, which gets a lot of attention from our healthcare organisations. The different care settings, again, we have some data. So we've got data for the acute setting, and here skin tears range from 6.2 to 11.1%. In the palliative care setting, which is where I work, it's a higher percentage, and it's up there to around 14%. Unfortunately, for certain care settings, we have no data. So within intensive care or theatres, we have no record of the amount of skin tears. We do not know the prevalence there. And again, I reiterate, I find these figures worryingly high for this wound type. It really concerns me. Skin tears themselves have complications associated with them, as do most wounds. But in skin tears, approximately 50% of them will go on to develop a wound infection, which is a high amount of people. In addition, they may become really complex wounds, especially if they're on the lower limb. And again, it's more complicated if there's presence of edema, if there's poor arterial supply, or poor venous return. These all will be complications and delays in the healing process. Perhaps one of the most common complications is the pain and suffering, because these are very, very painful wounds, as I said earlier, and they cause a lot of suffering to individuals, especially when they occur frequently and they have multiple skin tears. But sadly, in my experience, a lot of this pain and suffering can be alleviated because it's often caused by mismanagement on behalf of the healthcare provider. So what happens to elderly skin that makes it more vulnerable to pressure damage? Well, like most things as we age, the skin, the largest organ of the body, that changes too. So the layers of the skin haven't changed, the epidermis, the dermis and the subcutaneous fatty layer. But what happens to them? Well, the epidermis, the top layer of the skin that's visible to the naked eye, that becomes a lot thinner. So if it's thinner, it's less strong and more likely to tear. The junction, the epidermal dermal junction that becomes weaker. So this is there to bind those two layers of the skin together, and unfortunately, because it is weaker, the dermis and the epidermis separate more easily. There's a reduced blood supply to the skin, making it more vulnerable, and also we can lose sensation, especially if we've got conditions such as diabetes mellitus. One good thing maybe is we have less fat, but that is not such a good thing because the absence or reduction in the fat means we have not got as much padding there to protect us, and we're less able to resist trauma. So elderly skin in itself is greatly at risk. Let's look now at the intrinsic and extrinsic factors that put people at risk of developing skin tears. So the intrinsic factors, they start really for individuals who rely on help and care from others for their day-to-day activities such as washing and dressing. In addition, falls are linked to skin tears. So if patients have problems with things that affect their balance, they're going to be at risk. So we need to make sure we deal with issues that affect their balance and use walking aids, etc. to help them. Poor nutrition puts people at risk because the skin is not in such a good state, because the diet is not appropriate. And we also know that certain drugs will affect the patient's skin. If I asked you which ones, I'm sure you'd all say to me, steroids thin the skin, and yes, you're correct. That's a big problem for people who are on long-term steroids. We can't normally stop the steroids because they're on them for other conditions, but we need to be aware of what effects that will have on the skin. Mobility is an issue as well, especially if people need help to mobilise or to transfer, because this is a time when skin tears can occur. And we also know that smoking is detrimental to the skin. So what about the extrinsic factors? There are four main ones that I'd like to discuss with you. The first one is mechanical skin trauma. And again, I'm afraid that goes back to us as healthcare professionals. When we remove adhesive dressings and tapes, we cause skin tears. We have to go, though, perhaps at a different level and look at the individual healthcare provider as a person. So, do you and your healthcare team, have you got a good positive attitude towards skin tears? Like we have a zero tolerance to pressure ulcers, shouldn't we have a zero tolerance to skin tears too? And do you have the knowledge to prevent and manage skin tears optimally? And have you shared that with your colleagues, which hopefully you will do after this Facebook Live event? The physical environment can also be an extrinsic factor. If the patients at home have got a dimly lit environment and it's very cluttered, that's going to increase the risk of falls or knocking or damaging their skin. And finally, the healthcare setting itself can be an extrinsic risk factor. Because if where you work, you don't implement the ICETAP best practice, you're not providing gold standard care for your patients. So you need buy-in from your managers, your colleagues, and your healthcare setting. So, can I ask you, what do you think is the most common cause of skin tears? On the screen in front of you now, you can see the common causes. And I must admit, when I looked at the results of this study, which was done in 2011, I was not shocked by what I see on the screen, because it is relating very much to those intrinsic and extrinsic factors we have just discussed. The other thing I find, though, in clinical practice, when I look at the cause, is I'll see the patient, they'll have a skin tear, but often we don't know the cause. It was there one day, but not there the day before, and we're not quite sure why it occurred. So the cause sometimes is not always known. So, let's now look at how to assess and prevent skin tears. Let's get some good practical advice. In the ICETAP document, they start off with a skin tear risk assessment pathway, and I find this really, really helpful. So the pathway itself starts with risk assessment, which we've just discussed, because we need to know who's at risk so we can give the right care to the right people at the right time. You can see the factors there that put people at risk, and they need one or more of them to be classified as at risk. But two perhaps in that list that we haven't talked about already are visual impairment. And again, visual impairment doesn't help with mobility or avoiding hazards in the environment. But also a history of previous skin tears puts people at risk. And again, this applies to pressure ulcers, so I can see the sense and the rationale behind this. Because if you've had one before, you obviously have got those risk factors there as part of your condition. What they advise us then is, once we've established risk, is to implement a risk reduction programme. Because again, if we know someone's at risk, we are obliged to do something about that to reduce that risk. And within the document, there is an implementation risk reduction programme checklist, which I find is really helpful to check that I'm doing everything I possibly can to reduce an individual's risk of developing a skin tear. But what's also important in the pathway is to remind us to reassess, because the patient might not be at risk today, but tomorrow they may be. So when the patient's condition changes, we have to go back through the pathway, reassess the risk, and then follow it through and introduce the risk reduction programme. So what does his risk reduction programme include? Well, it talks about skin, mobility and general health. So let me take you through some of the examples of what's in the section on the skin. It talks about inspecting the skin. But to me, this is a fundamental aspect of nursing care. And a skin inspection should take place on a regular basis and involve all the skin, because as we know, skin tears can occur anywhere. So we don't want them to be a hidden epidemic, we want to find them if they exist. And we also need to investigate the previous history of skin tears. It's not just okay to know that a patient's had one, we need to know why they had one. And was it due to falls? Was it due to visual impairment? Was it due to the environment they were living in? So we really need to investigate that, not just write down that the patient had a skin tear in the past, because we can build that into our risk reduction programme. And to do that, we need an individualised skin care plan, because all of our actions should be within our nursing care plans, so that whoever's giving the care when we're off duty knows exactly what the risks are and exactly what they can do to prevent skin tears. The skin care plan and the detail within that is really important. It probably will include things like using a skin-friendly cleanser, pH balanced and not traditional soap, which we know dries the skin. And again, cleansing with warm water, not hot water, and patting the skin dry afterwards, not rubbing it. So basic skin care, but things that make a big difference to people with very vulnerable skin. As I mentioned before, any care plan should include preventing trauma from adhesives and dressings and tapes. So we need to be very specific in our care plans about what products we're going to use on our patients, so that we make sure the right product gets on the right patient at the right time. Example of things that will be in that care plan, I hope, are using silicone tape or silicone dressings and cohesive retention bandages that require no tape to keep them in place. So again, removing one level of risk. What else should we look at in the reduction programme in the skin? Well, protective clothing. If the forearms are covered, there's less chance of a skin tear occurring because we've got a physical barrier in the way. We can use shin guards for people's lower limbs. Make sure they wear, as I say, long sleeves, or even use bandages to protect the area. But that must be slightly controversial because we don't want the bandages to cause trauma. So correct bandages applied correctly. As well, we need to perhaps talk up to the patient about themselves and other healthcare providers such as carers. We need to make sure there are no sharp fingernails, no jewellery, especially during patient contact, because we know this damages the skin. And lots of times we ourselves as healthcare professionals, we're really good, we're always bare from the elbow down, but that's not always the same for informal carers or for patients who are looking after themselves. What does the risk reduction programme say about mobility? Well, one thing I picked up from it was about avoiding friction and shearing, because these were two of the traumas that can cause damage to the skin. So how can we do that? We can use glide sheets and we can use hoists. And I'm sure we've all got excellent advice on how to manually handle people so that we don't cause any trauma. And we must revisit our local guidelines to make sure we're implementing them correctly. I know it sounds quite simple, but ensuring that sensible and comfortable shoes are worn. Because quite often when I see elderly people, their slippers are quite old and they're not providing a nice base to prevent issues with balance or to help mobility. So look at people's footwear and see if they've got the best on that's going to help them not to fall or cause trauma. Other aspects to mobility is about a safe environment. So I said before, if it's dimly lit or cluttered, it's not so good, so we want adequate lighting and removing obstacles so that people can get around without trauma. The corners of coffee tables are a great hazard in the home. But what can we do for that? Well, we can pad up, can't we? We use padding for equipment such as wheelchair footrests, Zimmer frames and furniture. And this can make a big difference to people. It protects them straight away from those external traumas. When we talk about skin tears, I don't normally talk about pets, but the number of skin tears I've seen caused by cat scratches. So again, we need to make people aware that, pets themselves can be a hazard. So we need to protect people, and this is where perhaps covering their shins and keeping them covered will prevent scratches from pets as they jump on people's knees or rub against their legs. We need to be careful about the use of clothing. So if the skin tears occur on the forearms, when we're putting clothing on, we don't want tight clothing or lots of layers. So we need clothing we can get on and off easily, and that carers and patients can get on and off easily as well. But if we're using compression, which I'll talk about a bit later on, we need to make sure our compression is safe, that it's at the right level and applied correctly, and that the compression itself doesn't cause any trauma to people. The risk reduction programme also gives examples about general health. And here it talks about educating patients and carers on skin tear risk and prevention. Because as healthcare professionals, we're not there all the time. We're only there for a short period with our patients, and they need to know what they can do themselves to keep themselves safe and keep their skin in good order. And again, when we're writing our care plans for patients, they should be actively involved in that, especially in some of the care decisions, because without their buying, their understanding and their support, it's probably not going to occur. So this is where this true therapeutic partnership is really, really important. There's a paper that came out from Australia. It came out a couple of years ago now, I think, and it was a randomised controlled trial. And this randomised controlled trial was excellent science. It was a well-designed study and a well-executed study. So the highest level of evidence we have here to base our care upon. And what they did, they looked at people who were at risk of developing skin tears, and they did a very, very simple intervention. They made patients twice a day, the patients or the healthcare professionals, apply a moisturiser, an emollient to the skin. And just by applying an emollient twice a day to this elderly, dry, ageing skin, they reduced the reduction in skin tears by 50%. Now that is phenomenal. Absolutely phenomenal. Just think what that would do to your patients if you could implement that where you work. Because just a small change can have a really big impact on patient care and reduce your skin tears. So if we come across a patient with a skin tear, what should we do? The first thing we need to do is to cleanse and debride the area. So because the skin is so vulnerable and we've got an open, painful wound, we cleanse the skin very, very gently, and the surrounding skin as well. If it's been trauma, there might be debris in the wound, and sometimes, because of the bleeding issues in the skin in elderly people, we might have hematoma formation. And also we might have necrosis if the flap itself is non-viable. So if we have debris, hematoma or necrosis, we know we need to remove this before healing can take place. When we've done that with our cleansing process, we gently dry the surrounding skin to avoid any further injury, because moist skin separates easier than dry skin. But we don't want our skin too dry, it's got to be well emoliated. If we have a skin flap present, but it's not viable, as I said earlier, that will need to be debrided, because once it's not viable, it doesn't suddenly become viable, it's dead tissue. So you can see some skin tears there on the screen in front of you, and let's have a look at what we did here. Well, the first photograph on the left-hand side shows a skin flap that's intact, but the problem we've got here is it's dried out. So this is probably an old skin tear that's been discovered. Now, to get that flap to reapproximate or to recover the wound, we need to hydrate it. So what I would do is I would get some gauze. I would saturate the gauze in saline or water, whichever is your preference. And then I would put that wet gauze on top of the flap, the dry flap there. I'd leave it for 5 to 10 minutes. And then after 5 to 10 minutes, you'll see the second picture, the flap is now clean, it's moistened, and it's a lot easier to put back in place. You can see there that flap is being put back with forceps, but sometimes the quality of the forceps we have, especially in the community, don't help us with such a delicate operation. And some people prefer to use a gloved finger or a moistened wound swab to help to put the flap back in place. And then you can see finally the flap's been returned into its original position, and now we need to dress that flap and protect the wound bed and the flap. So skin tears, as I said, are acute wounds, and initially they will display the typical signs of inflammation, because inflammation is the body's response to injury, and here the skin has been injured by the tear and the blunt trauma. So the signs of inflammation around the wound are pain, redness, heat and swelling. But these are very similar to infection, so we'll talk about how to tell the two apart a bit later on. So we need to assess the level of inflammation. The other things I would assess about a skin tear are: where is it on the body? How long has it been there, if we know that information? The size of the skin tear. Obviously I always use the ISTAT classification system. I would look at the skin in the wound bed. Have we got viable or non-viable skin in the wound bed? I certainly would assess the patient's pain, and here I would use a pain assessment tool. We can also have got pain assessment tools for people with confusion and dementia. So pain assessment applies to everybody, especially our elderly population. I'd be interested to know how much edema is around the wound, because this, again, the swelling can help hinder, really, not help, it can hinder the healing process. So we need to help it by getting rid of the edema, which I'll talk about later on. And also, how fragile is that surrounding skin? Because I need to document that to make sure I protect that very vulnerable area. Another thing I do, if it's a skin tear on the lower limb, is I do an ankle brachial pressure index to assess how much blood is getting down to that lower limb. But if the skin is very vulnerable, sometimes putting the cuff around the lower leg can actually cause more trauma. So in these situations, I personally do a toe brachial pressure index, so I don't traumatise the skin, but I'm still able to assess the blood flow to the area. So when we're considering dressing, flaps, etc., what do we consider appropriate? Well, sometimes it's easy to consider what's not appropriate. And ISTAT themselves, in their recommendations, do not recommend using adhesive strips, or, as I know them, steri strips. And yet in minor injuries and A&E departments, these are still used today. So this is something we need to take back from this Facebook Live and make sure we get them out of those areas. Also, we shouldn't suture a flap back in place, because both the adhesive strips and the sutures will do more harm than good to a skin flap. So what should we be looking for in our dressings? What characteristics will help to promote wound healing? Well, some of the key things that I look for are dressings that have got gentle adhesion. Ones that are not going to cause any pain or trauma on removal. And here I'm talking about the silicone adhesives. And I do wonder myself, why would anyone use a dressing that's going to cause pain or stick when we've got marvellous dressings that come off easily without causing pain or trauma? To me, it's a no-brainer. I want a dressing that's soft and flexible so it can contour to the body. I want it to be breathable and to have good absorption properties, especially if I've got exudate levels due to inflammation and peri-wound edema. I want a dressing that gives me extended wear time, because I need to have that flap in place and give it time to heal and to settle. So I don't want to be disrupting that flap on a regular basis. Initially I will assess it, but then I want to cover it and leave well alone for the flap to realign. And shower-proof dressings are always helpful, because they mean that patients can get on with their lives and can revert to their usual activities of living. So when I'm applying a dressing, sometimes if the patient has gone via A&E or minor injuries, they may have used tissue adhesives to secure the flap. And that's fine with me, and that's good practice according to ISTAT. But again, when you're choosing the dressing, always have do no harm in the back of your mind. In my practice, we use foam dressings with a silicone adhesive, or we use a wound contact layer. When we're using a foam dressing, we always put an arrow on the outside of the dressing so we know which way to remove the dressing that is not going to cause trauma to the flap. And this is really important because otherwise it's a hit and miss situation. And then we leave the dressing, as I said, in place for several days to avoid disturbing that flap. If it's on the lower limb, we will apply compression therapy, and that's why we check the ankle or toe brachial pressure index, and then we will apply compression. Because what we find when we apply compression is it helps with the venous return and it helps to reduce the peri-wound edema, which both aid the healing process. So don't just think compression is only for VLUs, venous leg ulcers, it's also really good for skin tears on the lower limb. So on dressing removal, we now have Mepitel 1, and this is excellent because what we've got here, it's the only wound contact layer with a unique and helpful removal symbol. So that really helps us in clinical practice. What we want are things that are going to improve practice and help patients and keep them safe. So what I'm going to do now is show you a video about Mepitel 1, and it's about its application removal technique. So let's have a look at that. Hopefully you found that video helpful, and you can see there we've got something to help us in our management of skin tears. So okay, now we've dressed the skin tear, but we have to reassess the skin tear every time we do a dressing change. Initially, if you find the skin flap is exceptionally pale or dark, we really need to assess it between 24 and 48 hours to see if that flap is going to be viable, because if it's not, we have to remove it. We need to monitor the wound for changes, and we also need to maintain skin integrity. Importantly, we need to keep our eye out for signs and symptoms of wound infection. And as I said earlier, they're very similar to inflammation. So what are we talking about? Peri-wound erythema or redness, pain, an increase in exudate, malodour. And if you think about it, when a patient has an infection, whether it be a chest infection, a urine infection or a wound infection, they feel unwell. So we will check their general observations. A wound swab helps us to prescribe the correct antibiotics, but the actual clinical diagnosis of infection is not done by a wound swab, it's done by what you see on the patient. So keep your eye out for wound infection. If after 3 days after the initial skin tear, when you've got inflammation, that inflammation should now start subsiding. So if the peri-wound redness carries on for longer than 3 days, be thinking wound infection, and then we need to assess, manage and treat the infection. Sometimes wounds don't do as they're told or do what we want them to do, and they don't heal as we expect them to. So we'd normally expect a skin tear to close in a timely fashion, between 7 to 21 days. But if it's not, we need to see, are we missing something? We need to reassess the wound to see if there are any barriers to the healing process. We need to reassess the wound, as I said, for infection. But perhaps the patient's health needs assessment. Perhaps their condition has deteriorated, or perhaps their appetite has been lost. So again, we need to re-evaluate, especially if healing is not occurring as it should be. We need to revisit the risk reduction programme to make sure we've implemented every aspect of that. And also importantly, we need to continue prevention, because while we've got healing going on, we do not want any more skin tears to occur to our patients. So always keep prevention in mind as well as healing. So, to conclude, I think it's really important that we recognise individuals who are at risk of skin tears very early on, so we can put things in place to help them. One thing that I've hopefully got across to you today is to do no harm to our patients, so to make the correct dressing choices for them. The other thing is we need to know how many skin tears we have, so we need to start collecting data. Because as my boss, Professor Keith Harding, would say, if you've got no data, you've got no problem. And if we've got no problem, our managers will not listen to us and help us deal with this situation, which, as I say, can be even larger than that of pressure ulcers. And also, what I would ask you is to go away from this Facebook Live, to read the document, to read the best practice statement, but to take it back to your colleagues, to share it with them, and to implement those guidelines to make sure that your patient care is of the highest standard. That's enough of me. Let's move on now to our real-time question and answer session. And remember, you can take part at any time by commenting on the video. So let's move to our first question. So this question comes from Jane. Are patients with diabetes more at risk of skin tears? Yes, Jane, they are indeed. The big problem for patients with diabetes is the lack of sensation. So if you or I knock our shin or our foot, it hurts, and we make sure we don't do it again, and we check it. If you have no feeling in your foot, and in diabetes it's called a stocking-like distribution, so it starts at the toes and moves up the leg, you can be knocking your legs and you're not aware of it. So you're not getting that protective pain response. So yes, they're more at risk because of that. But also for healing, it's a bigger problem as well, because the blood supply to the lower limb in patients with diabetes is worse than any other members of the population. And that's why the highest risk of amputation rate is in diabetic patients. So they can't feel, so they're at risk of trauma, and also they don't heal as well because normally the blood supply is impaired, especially to the lower limb. So question 2 comes from Nicola. Here we are. Our guidance says not to use Steri-strips anymore. Good. However, not everyone is following this. Bad. Should we remove the Steri-strip and risk further damage, or keep it on? I would say remove it from where you work isn't the first thing to do, because if it's not there, they can't put it on. And that's what I had to do in a minor injuries unit where I worked. We had to physically take them out. The other thing is we are keen on wound care, and that's why we're all here tonight, because wound care is our passion. But sometimes in minor injuries, wound care is not necessarily their passion, and they might not be as well informed or as well read as we are. And Steri-strips have been around for a very long time, and people are reluctant to change. So it's about sharing what you've learned tonight with managers and with people who are using Steri-strips, because it might be that they just haven't seen the alternatives and know those alternatives that are much better for patients. If they're there and they have been put on, we really need to remove them, but we need to remove them perhaps using an adhesive remover so that we don't cause trauma, because this is the big problem. Removing them causes more trauma, so we really need to stop them getting on in the first place. I know that's a real clinical challenge, but it's one I would say to you, Nicola, you need to go back there and really try and sort that out and get rid of those Steri-strips. Question 3. What should we expect as a typical healing time for a skin tear on the shin in an elderly patient? Well, I don't know how long you've got, but I don't know if I can answer that question in the time we've got here tonight, because the patients heal in different ways and in different times. If it's a clean acute wound with no infection, with a good blood supply and no other comorbidities, I would expect it to heal within 3 weeks. But not many of the patients I nurse have got a good blood supply, have got good resistance to infection, and get good skin care. So I don't think I can give you a typical time. They would be for the most easiest, simplest skin tears. When it comes to the more complicated ones, when you've got no flap to go back, when you've got poor blood supply to the area, when you've got peri-wound edema in a very ill person, again, this can develop into a complex wound, and I've known them be there for many months. So I'm sorry I can't give you a clear answer to that. It really has to be on an individual assessment, and the more complex, the longer it's going to take to heal. Question 4 is from Stuart. How long do you recommend a dressing should be in place from first assessment before next review? Well, Stuart, that goes back to what I said about the state of the flap. Because normally if you think that flap is not going to be viable, we need to assess it within 24 to 48 hours. So in that situation, I would only have it in place for that long. But if you use a contact layer, you can actually assess through the contact layer without actually having to remove the dressing. So that might be a reason to use a contact layer initially when you're managing the skin tear. After that first review, if you're happy that things are okay, then I would use, where I work, the silicone foam dressings, and we would leave them in place normally for about 4 to 7 days, because we don't want to disturb that flap. We want to leave it in place and allow that flap to retake. So that would be my advice on that. But again, if you've got a lot of peri-wound edema and you can't put your patient in compression and there's more exudate, you might have to change it more often, because you don't want the exudate macerating that skin flap. So again, not a clear answer, but hopefully that might have been of help. Question 5 comes from Mary. How do we begin to collect incident data in our clinical practice? Excellent question, because this means to me that you're thinking about how you're going to do that when you get back to where you work. So look at how you collect pressure ulcer prevalence in your organisation and see if that can be transferred across to skin tears. So we need to know, perhaps are we going to collect prevalence, which we do an audit on one day, and have a look at all our patients and see how many skin tears are present on that day. And that gives us a snapshot of the size of the problem. Whereas incidence data is how many patients develop skin tears when they're in your care, and that's a more long-term data collection process. But that's really very helpful, because it helps you to pick up pockets of where these are occurring regularly, and then perhaps put the education into those areas to try and reduce the incidence in certain areas across the hospital or the organisation or the community. So perhaps the prevalence audit might be a good place to start. So you get a snapshot picture, but then look at perhaps developing incident data collection of an ongoing basis, so you can monitor how well you're doing, and hopefully the implementation of the ICE-TAP guidance should help you to keep your incidence low or reduce your incidence. But again, if it suddenly peaks, it gives you alarm bells, and you can go in and investigate that. So again, go back to how you collect your pressure ulcer data, have a look at that and see if the people that are doing that can help you then to do exactly the same for skin tears. Because remember, no data, no problem, no support, no finances. So we need that data. So I'm really glad that you're thinking about how you can do that. Question 6 comes from Alison. Apart from steroids, what other medications affect skin integrity? And this is quite difficult in a sense, Alison, because we have medications that cause things such as leg ulceration. An example is nicorandil and some of the drugs for hypertension. But if you think about skin integrity, we're talking about dryness of the skin, and we're talking about a lack of suppleness of the skin. But the main ones really to be concerned about in skin tears are steroids. Other medications will delay healing. And the ones that delay healing are things that knock out your immune system, because we know that the cells involved in the healing process are mainly the white blood cells, and the macrophages are the orchestrators of the healing process. So if you've got patients who are on medications such as cytotoxic therapy, cancer therapy, that knocks down the white blood cell count, that is going to delay healing and affect the skin and the ability of the skin to repair itself. Also, the first stage of the healing process is inflammation. So if your patients are on anti-inflammatories, that is also going to delay the healing process. But like I said earlier, with steroids and other anti-inflammatories, we can't normally stop them because of the effect on other conditions. So sometimes it's more to have an awareness of them and to raise it as a risk, because sometimes we can't actually stop the steroids. So it's drugs that affect the skin, but also the drugs that affect healing, such as your immunosuppressants, and your drugs that directly cause ulceration, not skin tears, such as Nicorandil, as I said earlier. Question 7 comes from John. How often do you think skin tears are misdiagnosed, and what is the impact if they are? I don't think they're often misdiagnosed. I've rarely come across this pressure ulcer category 2 skin tear, mainly because of where they are on the body, because mainly the ones I see are forearms and on the lower legs. So normally skin flaps, skin tears, they're normally correctly diagnosed. The problem I think they have is not so much the diagnosis, but the underreporting. People think, oh, it's just a skin tear. So, you know, it doesn't seem to have the same importance attached to it. So people often know what they are when they see them, but they don't often report them or record them or give them the importance they deserve. Because the impact of misdiagnosis may be that you're not implementing the correct treatment plan, and someone could put on a strong adhesive dressing that's going to cause more trauma. We saw the question earlier about people putting steri-strips on. So the diagnosis will definitely affect the treatment, because until the diagnosis is right, the treatment won't be right. So I think misdiagnosis can result in inappropriate treatment, and as I've said before, harm for our patients. And also it's not helping us to collect the data that we need to see the size of the problem. So I think it's about correct diagnosis, correct classification, and that classification is so easy to use, and auditing how many we are having and the impact they're having on our organisation as a whole. So I hope that answers your question there, John. Question 8 comes from Zoe. How do we remove a non-viable skin flap? Well, Zoe, that depends on your skill. On your skill as a nurse, and especially in relation to tissue viability. I would imagine that most tissue viability nurses, myself included, would use sharp debridement and would physically remove it. But if you're not happy doing that, refer to TVNs or a medical colleague to do that for you, because we need to remove that non-viable tissue. And if you think it's non-viable tissue, how would we remove non-viable tissue in any other wound bed? How do we get rid of slough and necrosis? By debridement. So again, we could use autolytic debridement, as I said, sharp debridement. They're not normally that amenable to mechanical debridement, and they're not normally that amenable to larval debridement therapy. So perhaps autolytic might be the one of choice in perhaps a community environment, but I would get a TVN in there to manually debride that and get rid of it straight away. Because the sooner it goes, the sooner the healing process can go forward. But again, there's an excellent documents, UMA document on debridement and the different methods of debridement that's got their limitations and guidance on how to do it. So that might be something you want to look at after this Facebook Live session, the UMA debridement document. Here's our final question of the evening, and this comes from Angela. Do you have any experience of skin tears becoming chronic wounds, and how would you manage that? Definitely, Angela. I have to say that tends to occur more on the lower limb than on the forearms. I find the forearms tend to heal a lot easier because they're not subject to problems with arterial flow and venous return. And as I said before, part of my assessment process is to do an ankle or toe brachial pressure index, and then I put people into compression. And I find the minute I put them into compression on the lower limb, that really does help to heal them in a faster rate. And I would do all the other things that I would do for a chronic wound. So I would assess the chronicity, I would assess the wound bed, and I would assess the patient. So anything else that's delaying the healing process, I would try and avert that and get the patient into a good place for healing. So here perhaps we're talking about wound bed preparation and application of the time matrix to identify things that are delaying healing and to prepare that wound bed to heal, along with compression therapy. Hopefully that advice is helpful to you. So, questions over, let's conclude. And this now does conclude our live training session. Any questions I've been unable to get to will be answered after today's event, so don't worry about that. We will definitely get back to you to help you with the queries that you have. I'd like to take this opportunity to thank Merlin-Nicker for their support this evening. And Merlin-Nicker have a special clinical team who can provide practical training and support. If you would like more information, please contact Merlin-Nicker, and the details are on the screen now. To access your certificate of attendance, follow the link also being shown on the screen for you now. I hope this has helped you gain a better understanding of the diagnosis and management of skin tears. If you have enjoyed this event today, please like the Wound Care Today Facebook page for details of upcoming events. Thank you very much for joining me this evening, and good evening.